in my view, the overall message to the referring community is that it relates to the fact that the decision-cto trial, although it's the first larger randomized trial in chronic total occlusions, is by no means the first data of good quality that we've had. We've had lots of good quality data prior to that around ischemia reduction, left ventricular function improvement, and symptom relief. And so although it's new, it's not coming to us in a vacuum. And the data that pre-existed it, in which in many cases I think was qualitatively better than what we got out of decision-cto, needs to be known. And we need to remind referring physicians just the broad categories of that data. And I've put together a couple of slides. In each of these categories, ischemia reduction, LV improvement, and symptom reduction, there are many, many studies to draw from, and I just picked a couple for each. I think this is the most impressive study for ischemia reduction we have from Sachdeva. It's only 3 years old, looking at functional flow reserve in a group of patients that had high-grade non-occlusive lesions with a resting FFR value, resting flow reserve value of 0.74, so really high-grade non-occlusive lesions, and comparing them to chronic total occlusions. And the first thing is, before you even give the adenosine, the values for a chronic total occlusion are profoundly abnormal, 0.64 in comparison to high-grade lesions, 0.74. And then when you give the adenosine, you get the lowest values we ever see, 0.45. And they normalize just like they do in non-occlusive lesions. This is the real thing. So there's resting ischemia in chronic total occlusions, and there's profound provocable ischemia, and it improves markedly. We've recently been putting patients into a study of stress echo and had to call it off because after 15 patients, 6 had ST segment elevation in response to the stress echo with chronic total occlusions. So these are profoundly ischemic patients, and there's just no question about that, and it's easily forgotten. People who don't do these procedures easily lapse back into the idea that these things are well collateralized, which of course we all know is not the case. Moving from that is the whole issue of left ventricular function improvement. And I think the general cardiology community puts a lot of stake in left ventricular function. It is one of those variables, one of those surrogates for outcome that is believed because it stood the test of time over so many different kinds of cardiovascular disease and over such long time periods of evaluation of outcomes. And we've known since TOSCA-1, which was back in the late 90s, that left ventricular function improves when you open an occlusion. It improves most in the patients that have the lowest EF, and the numbers for absolute EF improvement are not trivial. Even back in TOSCA-1, if your EF was below 60, just below 60, not below 40, below 60, your EF went up 3.8%. Absolute following recanalization at 6 months. And we've seen that reproduced in Gerald Werner's data. We've seen it reproduced more recently in MR-based data, which is obviously very accurate with respect to the measurement of left ventricular ejection fraction. And most recently, we've seen it, and I'm sorry Margaret's not here for this section, we've seen it reproduced in patients that have severe reductions in ejection fraction in this group, starting with an EF of 31%, rising to 38% after recanalizing a chronic total occlusion. So I think the EF data is very real. And then on to symptoms. We've already had this discussion. We've talked about the limitations of the symptom assessment in decision-cto. We have pre-existing high-quality decision data. This from John Spertus, the author of the SAQ, the inventor of the SAQ, showing that in this quite large sample, 167 CTOs and 2,500 non-CTOs undergoing angioplasty, the baseline symptom burden is worse in the CTO group, and it improves at least as much, if not more, upon treatment, despite the fact that the success rate was 85%. So there's a discount here where 15% were untreated. And yet with that discount that doesn't exist in the non-CTO group, the treatment benefit for symptoms was at least as large and statistically a little larger for the EQ5D. And we've seen and discussed already this information. What about safety? We've had a short chat about safety. I think these safety data from the recharge registry, Simon, that you've had such a big part of, are compelling. These are high quality sites achieving in the most complex patients a mortality of 0.2%, which, as we've talked about, is comparable to many other symptom-based surgical procedures that are widely accepted. And it's not far off, frankly, the average for angioplasty done in average labs in many centers around North America. So that's, I think, what I would say to the referring docs. We've got great information on ischemia, we've got great information on left ventricular function, we've got great information on symptom reduction that preceded decision-cto. And it aligns well with the experience we saw in euro-cto. So I think we're on a firm ground from a data standpoint to continue with this therapy.
Yeah, I think the safety point is well made. I mean, can we make it safer? Yes, we can. And should we make it safer? Yes, we should all strive to do that. But actually, the morbidity from the procedure is low, and the recharge endpoints were also validated and had an independent assessment. So I think those are real. It'll be interesting to see where it ends up compared to open. But those figures reflect the fact that certainly the mortality from the procedure is very low, and it's something that I think we can be comfortable to offer to patients.
And what I liked about Recharge was the large number of centers that participated. I think it's going to be one of the limitations of open.
Yeah, that's why it was designed, to show that it was more
it's broadly applicable.
Yeah, and more applicable.
Yeah. So 25 centers in Recharge, wasn't it?
Yeah, I don't know anymore about that because some came in later, but it's around 25.
Yeah.
Great. Your slide just showed that if you want to prove something, you have to go for a specific trial with a design that shows what you want to prove. In fact, and with the decision, I think it was too much a potpourri of everything, and that really has an influence, an impact on the outcome, and that's why the other trial was positive and decision.